All right, diving into some guidelines today, huh? Guidelines for evaluating new fever in adult patients in the ICU. Sounds like a mouthful, but an important one. Let's consider this our cheat sheet for this deep dive, shall we?
Yeah, absolutely. A cheat sheet for fever in the ICU. Because honestly, it can be deceptively complex, you know?
It really can, and these guidelines really highlight that right from the start, wouldn't you say? I mean, they even define fever specifically as a single temperature of 38.3 Celsius or higher. That's 101 Fahrenheit for those who think in Fahrenheit.
It's so true. Context is everything, even for something we think we understand, like fever. And you know what's interesting? These guidelines, they're actually useful even if we don't hit that magic number on the thermometer.
Right.
Yeah, if there's any suspicion of infection at all, these guidelines can be super helpful to guide your thinking, fever or no fever.
So it's like a roadmap for infection investigation, not just a reaction to a number.
Exactly.
Which, actually, speaking of numbers, leads to my next question. How are we even determining fever in the ICU these days? There are so many ways to take someone's temperature.
Oh, there are, but not all thermometers or the places you stick them are created equal.
Right.
I mean, the gold standard in the ICU, if a patient has one, is definitely the thermistor on a pulmonary artery catheter.
Sure, but let's be real. Not everyone's walking around, I should say lying around, with a PA catheter.
Yeah,
So what's next best?
good question. The guidelines specifically recommend oral or rectal temperatures as more accurate than the tympanic membrane, you know, the ear or temporal artery, the forehead, or those, what are they called? The chemical dot ones? Remember
Oh,
those?
yeah, the old school ones.
Yeah, kind of retro.
Okay, so oral or rectal it is. But I'm being honest, rectal temps in the ICU, logistically speaking,
Right.
not exactly everyone's first choice. Not the nurses, not the patients.
Yeah, and that's a good point for our listeners too. Where you measure really
Yeah.
does matter. It can actually impact your treatment decisions if you're relying on a less accurate reading, you know?
So we've got our temperature, we've got it measured in a reliable spot, and let's just say our patient has a fever. They're uncomfortable, maybe even a little delirious. So do we just reach for the antipyretics automatically?
Well, that's where things get interesting because the guidelines actually recommend against just routinely using antipyretics to lower temperature in these patients.
Wait, really? I feel like that's what we've always done, bring that fever down.
Yeah, it's a common practice for sure, but the evidence for it, at least routinely in all ICU patients, it just isn't really there. Like, there's not a ton of proof that lowering the number on the thermometer actually improves outcomes in the average ICU patient.
So are we saying never treat fever in the ICU?
Not necessarily. See, the guidelines are very clear that if the patient is visibly uncomfortable because of the fever, then yeah, treating that discomfort with meds is totally reasonable.
So it's more about the whole picture, not just fixating on the number, huh?
Exactly. We're not treating a temperature, we're treating a person. Comfort matters. So if that fever is causing distress, we address it. But just blindly targeting a specific number might not always be what's best.
Okay, so now we know how to define fever, where to measure it accurately, and when treatment might be appropriate. But that still leaves the big question. What's causing the fever in the first place?
Well, that's where the real detective work begins, right? And that's where these guidelines really shine. Well, when we're hunting down the culprit behind a fever in the ICU, imaging often takes center stage, wouldn't you say?
Oh, absolutely. Gotta love a good x-ray, right?
Right, and speaking of, these guidelines are very clear. A chest x-ray. It's a must-do for any ICU patient with a fever.
Makes sense to me. Pneumonia is so common in these patients. Got to rule that out quickly.
Exactly. Chest x-ray is our first line of defense. But, of course, sometimes things are a little murkier, right? The x-ray doesn't give us all the answers.
So when the initial x-ray isn't enough, when do we start thinking about the more high-tech imaging?
Good question. For those patients who've had recent surgery, think thoracic, abdominal, or pelvic, and the cause of their fever is still a bit of a head-scratcher, that's when the guidelines recommend a CT scan.
CT scans. Gotta love that extra detail.
Yeah.
But what about the even fancier stuff? PET scans? White blood cell scans? Those ever make an appearance in the guidelines?
They do, but sparingly. PET scans, they can be helpful, but only in very specific scenarios, you know? Like when every other test has come back inconclusive and we're still chasing that fever. But even then, we have to balance the potential benefits against the risks. Moving a critically ill patient for a PET scan, it's not without its risks.
For sure. Safety first. So what about those white blood cell scans?
Honestly, the guidelines don't really recommend them routinely for this.
Really?
Huh. Yeah, the evidence just isn't quite there to support their use for everyday fever evaluation in the ICU.
So we start basic chest x-ray and only escalate if we're not getting the answers we need.
Exactly. Got to be strategic. Speaking of strategic, what about ultrasound? It's everywhere these days, so commonplace. How do these guidelines address that whole world?
Yeah, it's the go-to for so much now, quick, painless. So I'm actually a little surprised to hear that a routine abdominal ultrasound just for fever alone isn't actually recommended.
I know, right? You'd think it'd be a no-brainer, right?
Totally.
And that the data just doesn't really show a huge benefit if there are no other abdominal issues going on.
Interesting. So it's all about weighing those benefits and risks, even for something as seemingly benign as an ultrasound.
Exactly. We're always thinking about that balance. Now, of course, there are definitely times when an abdominal ultrasound is the right call in a patient with a fever.
Yeah, I bet.
Yeah.
Like if there's some obvious abdominal issues already.
Right. Like if they've recently had surgery in that area, any kind of abdominal symptoms, liver function tests are wonky, anything like that.
Mm-hmm.
That's when a diagnostic ultrasound becomes super valuable.
Makes sense.
Mm.
Helps us avoid missing something serious.
Exactly. Like, for example, a calculus cholecystitis.
The calculus cholecystitis.
Basically, inflammation of the gallbladder, but without gallstones.
Mm.
It can be a tricky one to catch, especially in a really sick patient, and ultrasound can be really helpful in those cases.
Okay, so abdominal ultrasound, yes, but only when it's truly warranted, not just as a routine thing.
Huh.
What about the chest? I mean, we talked about pneumonia being so common, and a chest ultrasound just seems so much less invasive than a CT scan.
Oh, for sure. A chest ultrasound, it can definitely be a great tool, especially if that initial chest x-ray is abnormal. It can help us see things like pleural effusions or even pinpoint a specific area of the lung that's giving us trouble. But if the chest x-ray looks pretty normal, the evidence for doing a routine chest ultrasound just isn't that strong.
Got it. Be smart. Be targeted with our imaging. No more just-in-case tests.
Exactly. We're moving away from that shotgun approach, being much more precise, which actually that kind of leads us perfectly into another biggie in the world of infection, blood cultures.
The classic draw some blood and see what grows approach.
It really is a classic, and for good reason, right? It's essential for catching those bloodstream infections, which in the ICU can be really scary.
Absolutely.
And these guidelines, they have some really specific recommendations about how we get those blood cultures, especially in the ICU. For example, let's say we've got a patient, they have a central line in, and we're thinking, could this be a line infection? It's super important to actually culture the blood from both the central line and a peripheral vein at the same time.
Wait, so 2 pokes instead of 1? Not sure our patients are going to be happy about that extra needle stick.
Yeah.
But seriously, why both? Why is it so important?
Because it helps us figure out if the infection is actually coming from the line itself. See, by culturing them both simultaneously, we can compare how long each one takes to grow something. We call this time to positivity, right? So if that central line culture grows bacteria way faster than the peripheral blood culture, it's a pretty big red flag that, yep, the line is the source.
Oh, that's really interesting. So it's like we're catching the bacteria red-handed, right in the act. And if we already suspect the central line is involved, we should culture multiple lumens too, right? Just to be thorough.
Spot on. Each lumen gets its own culture. Can't be too careful.
Makes sense. Now, I got to ask about these new rapid molecular tests for blood cultures. They seem to be all the rage. Are they really the game changer everyone says they are?
They definitely have potential, I'll give them that. I mean, speed is everything in the ICU, and these tests are fast. Yeah.
But, and this is a big but, they don't replace traditional blood cultures entirely. Not yet, at least. Those traditional cultures, they can still grow a much wider range of those little buggers, and maybe even more importantly, they give us those antibiotic susceptibility results, and that is absolutely crucial for guiding treatment. Right.
So those rapid tests, they're a great tool to have in our arsenal, no doubt, but they haven't totally replaced the tried and true methods just yet.
Exactly. It's all about adding more tools to our toolbox, more information, faster, which actually, speaking of tests.
Let's do a quick rapid fire round on a few others.
Yeah, Lex.
Okay, first up, urine cultures. Are we still doing those routinely for fever in the ICU, like just to be safe? It's funny you should ask that because actually, no. The guidelines are pretty clear on this one. They actually recommend against doing routine urine cultures unless, and this is key, there's a real reason to suspect a UTI.
Okay, so no more just in case. Urine cultures. Got to have those specific symptoms or signs. What about viral testing? Is that something we should be thinking about in a patient with a fever, especially in the ICU?
100% yes. Especially like you said in the ICU, and especially if we're suspecting pneumonia. Viral infections, they can definitely cause pneumonia, not just bacteria, right?
Yeah.
And the good news is we've got those fancy multiplex PCR panels now.
So cool, right?
Totally. We can test for a whole bunch of viruses at once from a respiratory sample.
It's amazing how far we've come with diagnostics. Speaking of which, one last thing I wanted to get your take on. Procalcitonin, PCT. I've seen it popping up more and more. Fill us in. What is it, and how does it fit into this whole fever puzzle?
Oh, PCT is a good one. It's a biomarker, and along with CRP, C-reactive protein, it can actually be really helpful in guiding our antibiotic use.
Really?
Yeah, and not so much for starting antibiotics, but more for figuring out when it's safe to stop them.
Oh, that's interesting. So it's more of a de-escalation tool than an initial diagnostic tool.
Yeah.
Help us make sure we're not overdoing it with the antibiotics, which is always a good thing.
Right, and they're most helpful when we're on the fence about a bacterial infection. Like, if we're already pretty darn sure it's bacterial, they don't add much value up front. But in those less clear-cut cases, they can be super informative.
It's like they help us fine-tune our approach, avoid those unnecessary treatments. This has been eye-opening. It's incredible how much nuance there is to fever in the ICU.
Yeah.
Something we often think of as pretty straightforward. It really makes you realize, doesn't it, that we can't let ourselves get complacent, even with something as seemingly basic as fever,
Yeah,
especially in the ICU.
absolutely. It's easy to fall into those traps of assumptions, old habits, you know how it is. But we have to stay curious, stay up to date, and I think most importantly, really remember that we're treating a patient, a person, not just a temperature on a chart.
It's so easy to get caught up in the numbers sometimes, But like you said, it's about recognizing the whole picture, each patient as an individual. And that's really what I appreciate about these guidelines. They're not just like a rigid set of rules. They're more like,
A framework.
yeah, exactly, a framework for thinking critically, for tailoring our care to each unique situation.
That's a great way to put it. It's about being thoughtful, being systematic, but also being flexible, you know? We're not just treating a temperature in isolation. We're using the best evidence we have to figure out what's causing it, to target our interventions in a way that truly benefits the patient.
So if we were to boil all of this down for our listeners, what would you say are the absolute key takeaways about evaluating fever in the ICU? The must-knows.
Okay, well, first and foremost, I think it's crucial to remember that fever in the ICU, it's rarely simple, it's complex, and we need to approach it with that understanding. Recognize the challenges, choose our diagnostic tools wisely, and be ready to adjust course based on what each individual patient needs.
So it's like being a medical detective in a way, right?
Exactly. You said it, not me.
Gathering the clues, putting the pieces together, and then making those informed decisions.
And then sometimes reevaluating those decisions when new information comes to light. That's the beauty of it.
So true. And that brings us to another really important point, I think, which is this. We have all this amazing technology, all these diagnostic tools at our fingertips,
Yeah.
which is incredible. But we also have to balance that
With not going overboard.
Exactly. Like, we have to be able to harness the power of these tools, yes, to get answers, to guide our treatment, but we also have to be so mindful of the risks of over-testing, of doing things just because we can, not because it's necessarily going to benefit the patient.
Finding that sweet spot, right. Thorough, but not excessive.
100%. It's a constant balancing act, and it really speaks to how medicine is always evolving. We're always learning, always refining our approaches, and these guidelines are a perfect example of that.
I completely agree. It's a good reminder that no matter how long we've been doing this, there's always more to learn, more to discover. And that's exciting, isn't it?
Absolutely. Keeps things interesting, that's for sure. Well, this has been a fascinating deep dive, wouldn't you say? Really digging into all the nuances of fever in the ICU.
I've really enjoyed it.
Me too. But as always, we want to leave our listeners with something to chew on, something to keep those brain gears turning. So here's a final thought. As technology keeps advancing at this incredible pace, how do we make sure that our clinical judgment, that human element, keeps pace? How do we make sure our brain stays sharp as our diagnostic tools? It's a challenge, for sure, but a crucial one.
It really is. It's a conversation we need to keep having, keep exploring. That balance between technology and human expertise, that's where the magic happens.
Well said. And on that note, we'll wrap things up. Thank you, everyone, for joining us for this deep dive into the complexities of fever in the ICU. Until next time, stay curious.